So we've been working on the development of this clinic within the CAP division over the last 3 years, and the goal has been to develop the ability to provide short-term outpatient care for youth in crisis, linking between levels of care. I do really want to highlight that this work has really been a collaborative effort. So Krista Parrish, prior to her departure, was intimately involved in this work. And I'm really excited about the leadership that's underway with our new faculty member, Dr. Summerhalder, and our postdoctoral fellow, Dr. Radke, who will actually be joining the faculty this summer. So today will be a sample of the work, and hopefully we'll have a lot more to share over the next several years. So in terms of the objectives and plan for what I'll be talking about today, I'm going to provide an overview of the current status of youth mental health and the need for timely access to care. I'll start by talking about what we know nationally, and then talk about what we've been experiencing locally here. And then I'll go into the details in the development of our Bridge Clinic, share our preliminary findings and ongoing evaluation plans, and talk about our successes and challenges. So it's been well highlighted this year within our grand round speakers, particularly Dr. Zaim and Dr. Schwartz, that youth mental health is of serious concern. So HHS data found between 2016 and 2020, the number of children ages 3 to 17 years old diagnosed with anxiety disorder grew 29%, and those with depression by 27%. Suicide is a leading cause of death among youth in the United States, as shown here in the picture on the bottom right. And then the CDC Youth Risk Behavior Surveillance data has shown the increase in challenges that youth have been experiencing. So some of the key findings have been that 1 in 3 high school students experience persistent feelings of sadness or hopelessness, a 40% increase from 2009 to 2019. And then furthermore, in 2019, 1 in 6 youth reported making a suicide plan in the past year, which had been a 44% increase since 2009. CDC had a press release last week that particularly highlighted teen girls. And as shown in this graphic from the CDC, it says that nearly 3 in 5, so 57% of US teen girls felt persistently sad or hopeless in 2021. That was double that of boys and representing nearly a 60% increase and the highest level reported over the past decade. So this has been accompanied by an increase in the demand for acute care services that really, I'm going to try to highlight that this was happening before the pandemic, and then some of the unique challenges, obviously, that the pandemic brought. So pre-pandemic, there was a significant increase in inpatient hospitalizations for mental health conditions for children. For those ages 10 to 14, hospitalizations for mental health conditions increased nearly 50%. Inpatient visits for suicide attempt, suicidal ideation, and self-injury increased 104% for all children, and particularly though high for children between the ages of 10 and 14, 151% increase. A recent report from JAMA Pediatrics shows that there was an overall visits to pediatric emergency rooms for mental health crises increased 43% from 2015 to 2020. This was a rise of 8% per year on average, with an increase in emergency visits in every category of mental illness. By comparison, emergency room visits for medical conditions only rose 1.5% during that same time period. The study highlights that ED services often have poor coordination with follow-up care, leading to low follow-up rates and high rates of ED revisitation. And they found there were a few diagnostic groups that had particularly high risk for revisitation, including those with psychotic disorders, disruptive or impulse control disorders, and neurodevelopmental disorders. And then to separate then into the pandemic, what are we seeing? The early 2021 emergency department visits in the US for suspected suicide attempts were 50% higher for adolescent girls and 4% higher for adolescent boys compared to the same time period in early 2019. So what we're seeing is that the demand for acute psychiatric emergency services and inpatient beds is really increasing, while the number of beds available is either decreasing or remaining static. And then thinking specifically about the pandemic, there were certainly further disruptions in continuity of operations and reduced bed capacity as a result of staffing and other infection mitigation strategies. So this leads to this impact for delays in treatment, exacerbation of symptoms while awaiting care, and then boarding. So boarding, as Dr. Zain talked about last week, refers to the practice of holding patients who are awaiting admission or transfer to an inpatient psychiatric facility. Titles here reflect really the regional and national media attention that has been brought to this issue. So rates for pediatric mental health boarding in EDs and on medical floors was really catalyzed by the increasing demand and insufficient number of inpatient beds and limited alternatives to admission for youth with acute mental health needs. A recent review of pre-pandemic pediatric mental health boarding found that the average boarding times in the ED vary greatly from 5 to 41 hours, and that average boarding on an inpatient medical floor ranges from 2 to 3 days. And this results in about a quarter to a half of those who actually get an admission to an inpatient unit having first experienced boarding. With regard to the impact of the pandemic, a survey of hospitalists across the US and Canada reported that 75% reported an increase in boarding, and not just the overall amount of boarding, but the actual duration of boarding as well. So given the crisis of youth mental health, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Health Association declared a national state of emergency in children's mental health. This was in October of 2021. And the declaration notes the dramatic increase in the number of youth presenting to emergency rooms for mental health emergency, and concludes that we must identify strategies to meet these challenges through innovation and action. A number of recommendations were made, including increasing federal funding to ensure access to evidence-based mental health screening, diagnosis, and treatment, addressing regulatory challenges, and to assure continued availability of telemedicine, increasing implementation and sustainability of school-based mental health care, accelerating options and financial sustainability of integrated mental health care and primary care, strengthening efforts aimed at reducing risk for suicide in children and adolescents through prevention programs, addressing the ongoing challenges of acute care needs of children and adolescents, including, as I've been describing, the shortage of beds, emergency room boarding by expanding access to step-down programs for inpatient units, short stay stabilization units, and community-based response. There are a number of other recommendations too, again, also that are also focused on reimbursement and ensuring compliance with the enforcement of mental health parity laws. So soon after this declaration, the US Surgeon General issued a public health advisory calling on the nation to respond to the growing mental health crisis impacting young people that had worsened during the pandemic. And this report really highlights the individual, family, community, environment, overall society, both the impact as well as opportunity for increased supports. So I've been describing what we've been seeing nationally and then what's been happening locally. So our pediatric ED here in the Children's Center has certainly not been immune to these challenges. Prior to the pandemic, the mental health crisis was certainly being reflected in the number of patient visits, which is shown on the bottom, the data on the bottom here, which is ED psych visits by month. And you can see that October 2018 was really the peak. Significant concerns with boarding were being observed. I have a quote from a concerned parent that said, "It took 3 years to get a bed. It's or not 3 years, 3 days to get a bed, excuse me. It's exasperating to have patients waiting so long. Treatment is delayed, patients ultimately suffer." In efforts to understand and characterize these concerns, I participated in a chart review with colleagues from the Ph.D. looking specifically at boarding. Again, this was pre-pandemic, and found that there were approximately 200 patients per year that board in the ED, and that was defined as over 24 hours. Boarding commonly occurred during school months, which really reflects what we see seasonally in terms of the demand for acute care services. The most common chief complaints included suicidal ideation, attempts, and disruptive behavior disorders. Outflow factors that directly were impacting were bed availability, transferring to another facility, and then ability to transition from emergent to outpatient care seamlessly. And just to talk about that ability to transition out, Dr. Zaim has been leading an effort on chart review data from the emergency department, and certainly found concerning rates of lack of documentation, or maybe not just documentation, but in terms of follow-up. So during this time period for pre-pandemic, as part of the chart review, saw that a significant portion of patients were being discharged without documented follow-up within 1 week. And we know that timely follow-up can improve patient outcomes and decrease the likelihood of revisitation. So what was happening with bed availability on Bloomberg 12 South, our child and adolescent psychiatric inpatient service? Our inpatient service has observed an increase in acuity, including the percentage of patients who are admitted following a suicide attempt. This has really been accompanied with increasing lengths of stay and high occupancy rates. As a result, a sizable proportion of those seeking admission, 75%, are not able to be admitted. And this is most often as a result of full occupancy. Longer lengths of stay mean that there's less throughput. And so we've collected information on reasons for stays past 7 days, and saw that there were patients who were awaiting, who weren't discharged as they were awaiting follow-up appointments, or there was an effort to minimize time between discharge and the follow-up appointment. And so we found that in 11% of cases. And so this graphic is meant to show the challenges that we're seeking. Certainly not a graphic artist, but what I'm trying to show here is that we have 15 inpatient beds we have 12 slots in the day hospital, 5 of which were offline for some time due to need for distancing for HEIC requirements. And then you can see trying to reflect here that there's a high number of patients being referred. And so we, in trying to meet these needs, we need ways to decrease bottlenecks, like waiting to discharge for follow-up, waiting follow-up appointments, and safe outflow from the emergency department. And so to meet these challenges, really a multi-pronged approach is needed really to make an impact. And so with Dr. Campo and Grados at the helm, a number of efforts are underway to increase overall capacity and ability to treat across our continuum of care. And just to highlight some of those efforts, right, in the ED, working on specialized psychiatric services to improve assessment, front-load evidence-based treatment, enhance patient flow. Dr. Zajac and Park are leading efforts within our inpatient and day hospital to provide care that's efficient, effective, and safe. We have Dr. Zaim and Platt and Bentoncourt leading efforts with integrated care. We've been trying to engage stakeholders to increase access to specialized treatment programs, quality out-of-home placements. We've been involved with advocacy work with legislative affairs at the state level. And then finally, this additional piece that I'm talking about today was the addition of a bridge clinic, which was designed to try to provide timely access to short-term care on an outpatient basis. So what is Bridge? We had originally referred to this clinic as urgent care, but over time the title evolved to reflect the focus on brief outpatient triage and intervention services with a focus on providing time-limited care between levels of care. So you can see in this graphic here, we have the kind of continuum from emergency department, outpatient, partial hospitalization, and inpatient. And so the idea is to provide outpatient bridge appointments, so referrals from the ED to outpatient or day hospital, referrals from inpatient to day hospital or outpatient, and then referrals from day hospital or partial hospital to outpatient care. The short-term services include brief individual and family psychotherapy interventions, ongoing safety planning and assessment, care coordination, including facilitating transitions and coordinating care between programs, psychiatric medication management, consultation and treatment. And the idea is that we were trying to prevent bottlenecks, providing a safe alternative to help decrease ED boarding, and when clinically appropriate, being able to discharge a patient from the ED, and then also decreasing bottlenecks by helping move patients out of the CAP inpatient and day hospital when clinically ready for discharge and awaiting follow-up care. Again, I really want to highlight that this has been a collaborative effort, and this is reflecting some of the folks that have been involved. So Dr. Parrish and I started this work working closely with Dr. Grados, and Dr. Sommerhalder and Dr. Radke have now taken the clinical lead and have been partnering with Dr. Zaim and Kalari and our advanced practice provider, Priya Parimal. And Diane Pickett from social work has been key in the multidisciplinary effort, coordinating with social work across our care settings. Renee Williams, our clinical operation manager, has been supported our administrative processes. And Robbie Berg has been involved in our data analyses and has submitted a poster to abstract to Pediatric Academic Society about this work. Okay, so what has been the process in terms of developing this clinic? We started by reviewing models from other health systems. There was a business plan approved in 2020. Our pilot began in 2021, January of 2021. We had increased capacity in late summer 2021 through inclusion of our psychology postdoctoral fellows. And then our current primary psychology team took over in the summer of 2022. Okay, so in terms of models from other healthcare systems, there are two examples that we've looked to and as ways to have an understanding of what might work and some inspiration. And those are from Duke and Seattle Children's Hospital. So Duke has a program called the Children's Evaluation Clinic, which was designed to address care issues as well as ED flow. And so it's a brief outpatient program staffed by social work, psychology, and psychiatry. They provide up to 5 sessions. They have 2 safety slots a week, which focus on safety planning and referral coordination. And slots are given to the ED, scheduled directly with no barrier. And the ED has control of these slots, so patients can discharge from the ED with this follow-up appointment. And a psychiatrist is available when indicated. The clinic uses a family-based crisis intervention approach, and they have been able to share some pretty positive outcomes in terms of reducing length of stay in the emergency department, decreasing ED revisitation, and then also really spoke to ED provider morale. And so this idea of having a quality place to send patients from the emergency department. A similar model was developed at Seattle Children's called the Behavioral Health Crisis Care Clinic, which was designed to provide brief, just-in-time intervention to youth and caregivers. The goal of the treatment is to provide an alternative to inpatient psychiatric hospitalization by stabilizing the crisis via safety planning, family communication strategies, treatment planning, and really robust care navigation. Care pathways for adolescents. They have 2 care pathways, one for adolescents with suicidal thoughts and behavior, and then another care pathway for children ages 5 to 12 with disruptive behavior. And their findings suggest feasibility and acceptability of the model, significant decreases in self-reported suicide risk for the care pathway for the adolescents, low levels of ED utilization during the clinic time and at 1 month post-treatment, and then high rates of linkage to ongoing care. So in designing our bridge clinic, there were a few two kind of key essential pieces that we were focused on. And these were timely access, and then really having a family-based approach. So really trying to support parents and caregivers. So with regard to this timely access, care quality metrics recommend that youth be seen for that are seen for acute psychiatric care attend an outpatient mental health appointment within 7 days of ED or hospital discharge. And we know from work that Dr. Campo has been involved in that mental health follow-up received within 7 days of discharge is associated with reduced risk for suicide during the 8 to 180 days after hospitalization. With regard to supporting parents and caregivers, we know that having parent involvement is really associated with improvements in outcomes in evidence-based treatments and interventions across a range of diagnoses. And we really see parents being key part of providing psychoeducation, lethal means restriction, and really trying to focus on skills training aimed at increasing caregivers' ability to effectively manage crises. And so with that goal of using a family-based and really engaging caregivers in our Bridge Clinic, we received training in family-based crisis intervention, which is an intervention that was created primarily to provide optimal care for suicidal adolescents. FBCI sees breakdown in communication within the family as often contributing factor to a crisis, and has really the goal to provide families with tools to help them through current and future crises. The idea is that the family, a family that learns to support their child when he or she is in crisis, will be empowered to continue to provide ongoing support once the acute psychiatric crisis subsides. There are a number of key treatment components that we have adopted across the range of patients that have been referred to our Bridge Clinic, but these include assessment, crisis narrative, risk formulation, psychoeducation, safety planning, some preliminary kind of basic CBT interventions like identifying and challenging cognitive distortions, introducing coping skills, and treatment planning. Okay, so as I said, we started with an initial pilot of Bridge in January of 2021. And really, this was our kind of initial pilot until August of 2021. And this pilot really gave us a number of important lessons. First, we were really pleased to see that there was really high engagement, and that overall the Bridge Clinic was really well received by patients and caregivers. Next, we learned that the patients were presenting with high acuity. For example, patients that were referred following a suicide attempt. We also learned during this pilot that the needs definitely extended beyond patients with suicidal thoughts and behavior. So, for example, the first 3 referrals were patients under the age of 10 with aggressive and disruptive behaviors. We also learned that to have capacity within the Bridge Clinic, you have to have an end to the bridge. And so we recognized that there were really pretty significant case management, care navigation needs, most notably needing support submitting referrals, navigating insurance coverage, and also needing to create capacity within intermediate and outpatient care. So, for example, being able to accept patients within the day hospital and other clinics. We also learned during this time that we needed to create a referral process that was available 24/7, and that really there needed to be this continuous kind of education on the purpose of Bridge with all those involved. Okay, so this is kind of going into the weeds with a lot of specifics here, but I want to give some specifics on what we've evolved to. And so the Bridge Clinic that we talk about is designed for short-term care, so 1 to 5 sessions. And the objective is to support stabilization and safety as a patient moves through different levels of care. Referrals come from the ED, day hospital, psychiatric inpatient, and then the medical floors here in the Children's Center. Sessions are conducted by a licensed psychologist or a psychology postdoctoral fellow under the supervision of a licensed psychologist, and our nurse practitioner or psychiatrist is available when needed. Patients are first seen by psychology, and then psychology helps facilitate and coordinate the referral to psychiatry. The first session needs to take place in person in our clinic on the 12th floor of the Bloomberg Children's Center. And we then assess kind of availability to attend additional in-person sessions and are able to move to virtual or telemedicine when clinically indicated and appropriate. For emergency department referrals, the ED social workers have the ability to schedule bridge appointments in available designated slots. There's open slots in a calendar. So scheduling does not need to have to be approved or accepted by the bridge clinic. The patient can discharge from the ED with this follow-up bridge appointment. Patients need to be bridging to another level of care within a known time frame. The bridge clinic is available for both internal and external disposition sources. The bridge appointment needs to be scheduled within a week of ED discharge. Outpatient appointment and mental health codes are billed. And we've learned about insurances, right, that tend to work well in terms of authorization and coverage of services. This is an example of the EPIC referral info that the ED uses to submit referrals, reflecting some of kind of the key information that's provided. Okay, so after the pilot, up until December 2022, I have the preliminary data here, and this data that I'm initially presenting on these next two slides is focused on the bridge patients from the emergency department, and then I'll talk a little bit about cases from, excuse me, the inpatient unit and day hospital. So from the emergency department, there were 62 patients, so just under one patient a week. The fall has tended to be the time for the most referrals. In terms of demographics, majority of the patients identify as female. Patients ranged in age from 6 to 17 years old, with the mean age just under 14. 50% of the patients had Medicaid for their insurance, and the majority of patients were from Baltimore City or Baltimore County, and the furthest patients were from DC or Delaware. In terms of clinical descriptors, the most common chief complaints at ED presentation were suicidal thoughts and behavior, followed by aggression, elopement, and then emotion dysregulation is kind of a broader term. Of those with suicidal thoughts and behavior, 22% of those had taken some action, most commonly ingestion. Of those who could complete the PHQ and the GAD-7, the PHQA found the average score fell in the moderately severe range, and the GAD-7 average within the moderate anxiety range. So initial bridge clinic appointments on average occurred 3 days after ED discharge, and patients attended between 1 and 7 clinic appointments with a mean of 2.8 appointments. In terms of utilization, 90.4% of patients attended at least one appointment. Of those who didn't attend an appointment, it's broken down, split between those who returned to the ED prior to the bridge appointment, and then the other half who no-showed and were not responsive to attempts to reschedule. ED revisitation at 1 month and 2 months for these patients was 11% at 1 month and 16% at 2 months. And this is pretty comparable for other published work that looks at these kind of crisis short-term care programs. Of those who attended at least one appointment, 100% were connected to follow-up care. And so if you attended the bridge appointment, we were going to connect you with follow-up care. So in sum, it's brief treatment. We have preliminary indications of safety. There were no safety events despite a sample of primarily adolescents with suicidal thoughts and behavior, and moderate levels of reported anxiety and depression symptoms. Okay, so now focused on the from inpatient or day hospital referrals. The and these were patients, right, that were able to be discharged because they were clinically ready, but there was some type of gap with their follow-up appointments, and so they were referred to Bridge in the interim. So we have approximately 1 referral per month of these patients. Patients attended between 1 and 6 appointments, with a mean just under 2. The majority from inpatient were stepping down to a day hospital or outpatient, intensive outpatient program, and the majority from day hospital were stepping down to outpatient care. Okay, so I'm going to quickly just go through three different case examples to give you a sense of how this Bridge clinic has been used. So the first, this is an example of an ED Bridge, so a patient that was in the emergency department and referred to Bridge. So a 15-year-old female with a history of social anxiety disorder, avoidant restrictive food intake disorder, who presented with depression and suicidal ideation with the onset of about one year of these concerns. The patient reported intermittent thoughts of harming self, no plans, and no attempts in the past were reported. There was a positive ASQ screen shown here on the right side of the slide. And this is the standard suicide screening tool that's used in the ED. Let's see, the patient lives with her parents and older sister. The patient did not have any current providers and last had providers over a year prior. Patient was in the PZD for 6 hours and 45 minutes, was assessed by a PZD physician and social work, assessed to be at low suicide risk. Protective factors were identifying reasons for living, supportive social network, engaged in school. So with regard to Bridge, the initial Bridge appointment was 1 week following the ED discharge. Patient had 5 total Bridge sessions, 4 with psychology and 1 with psychiatry, and then started in the Bayview Adolescent Intensive Outpatient Program. Psychology sessions focused on assessment, psychoeducation, safety planning, sleep hygiene, behavioral activation, and problem solving. And then for psychiatry, there was assessment and then initiation of a medication. The patient now is followed at Bayview with outpatient providers, has not had an ED or an inpatient care since then. So without Bridge, what could have potentially happened for this patient? You could make a few guesses, or there are a couple different potentials. Maybe staying in the ED longer, awaiting a solid follow-up plan, or potentially discharging with a less certain or less kind of guaranteed follow-up plan. Okay, so now an example of a Bridge from that was from our inpatient unit. So 14-year-old male with a chief complaint of worsening aggression, diagnosed with autism spectrum disorder and ADHD. He had had 4 hospitalizations within a 12-month period, and then had a prolonged inpatient stay due to a lack of placement. This patient was in DSS custody, so had been on the inpatient unit for 4 months, and throughout that 4 months, we're actively searching for a placement for this patient. Once placement was found, the patient discharged to an alternative living unit. There were psych providers were not readily available, as this placement was found like relatively quickly after the end of a long wait, right? And so this patient was referred to Bridge. The initial appointment was 3 days following inpatient discharge. There were 5 total Bridge sessions over about a month period, 3 with psychology and 2 with psychiatry, and then follow up with community providers that were connected to the school agency he was placed in. And so in terms of the psychology appointments focused on assessment, safety planning, consultation with the group home on basic behavior management principles, care coordination with DSS, school, and the new providers. And then for psychiatry assessment, medication monitoring. This patient has not been in the ED or inpatient care since discharge. And if we're going to guess like what would have happened had the Bridge Clinic not been available, potentially could have had an extended stay, continued extended stay, I should say, awaiting follow-up care, or potentially a discharge with this suboptimal transition. Okay, and last is an example from our day hospital. So a 17-year-old female with no significant past medical history who had presented to Howard County General Hospital Emergency Department for increased energy, grandiosity, decreased need for sleep, increased irritability, concerning for acute mania. Patient was transferred to Bloomberg 12 South inpatient unit, had a 12-day stay, 12-day admission. Discharge diagnosis was bipolar disorder with psychotic features, current episode manic. After inpatient, the patient had next day follow-up with our CAP day hospital, where she was for 7 days. The plan was to refer the patient to the specialty program at Bayview that Dr. Miller runs. There was a gap in terms of availability, and so the patient was referred to Bridge and had 4 sessions with psychology and 2 with psychiatry. The first session was within 5 days of day hospital discharge. And the sessions focused on assessment, safety planning, coordination with school, education, supporting sleep routine, medication adherence, and psychiatry assessment, psychoeducation, medication titration, and monitoring. The patient has not had an ED or inpatient care since. And so what would have happened without Bridge, potentially could have had a longer day hospital stay or not been able to land in such a high quality outpatient slot. Okay, so to kind of be summarizing and wrapping up, what do we know? What are we thinking so far about our Bridge Clinic? There are certainly lots of positives. We're really pleased with the engagement with patients and families. There's a high attendance rate, good completion of our standard measures. We feel like preliminary outcomes are encouraging, particularly with regard to safety. I will say there's been really good satisfaction and a sense of purpose for Bridge clinicians. And this is personally quite true for me. I found this work incredibly reinforcing, holding patients and families through this really high stress time. We've also seen really what we think strides with our system integration, including this really multidisciplinary case planning with our social work teams and CAP providers. So this is not fiscal year, calendar year 2022 with PDD data. And we're feeling encouraged by this is the length of stay in minutes, right, for the ED. And you can see the light blue line is for behavioral health patients. And we're feeling encouraged by the decreased time from July onward, when there were multiple pieces of that multi-pronged approach in place, including Dr. Kalari in the ED, along with Priya. The Bridge Clinic solidly transitioned. Initially summer months make a lot of sense seasonally with typically lower demand, but we're feeling encouraged by September onward, which you can see on the bottom part, the higher rates of overall AUD visits. This is kind of our hot off the presses from Dr. Radke on Friday that talks about January and so far in February, what we've seen. And just again, to see that, there's been high engagement during this time. This is for the ED specifically. Some challenges that we're experiencing, right? There's variable flow, insurance coverage. So some patients that come to the ED are out of network with our outpatient care. Really noticing the care navigation needs with supporting linkage to follow-up care, transportation, insurance coverage, and that certain populations are more difficult to bridge than others due to a lack of overall resources. So for example, in the state of Maryland, there's very limited, if any, PHPs or intensive outpatient programs for children under the age of 12. Something the Children's Center IOP at Bayview closed earlier this year. And then access for therapeutic services for youth with developmental disabilities. Dr. Lopez has led the charge in terms of access for psychiatry services, but getting that therapeutic side of the services in a timely manner is a challenge. So one of the hurdles with Bridge is that we feel like is impeding our kind of full realization of our goals is the current requirement to have an identified end to the bridge at the time of the referral. And this requirement is largely because we don't have a dedicated care navigator, and there's need to grow capacity within our continuum of care for higher acuity patients. We know that care navigation is considered to be really an essential component of crisis care and has impacts, positive impacts on follow-up care, reducing suicide attempts. And so there's a business plan underway that has care navigation as a prioritized component. And we feel like this would be a means to really help increase capacity and impact of the Bridge Clinic. In terms of future goals, we'd love to build out interventions to support success for patients. And so potentially longer stays in the day hospital, or I'm sorry, within Bridge when indicated, for example, to be then able to support a patient's success within a day hospital or intensive outpatient program. And so potentially more behavioral parent training or exposure work for those patients that experience lots of anxiety in kind of group-based treatment settings. We're also considering the idea of having planned assessment triage spots and like other models do, but potentially starting with being able to take referrals from primary care, access to 24-hour crisis call given to support safety given the overall high acuity, and then dedicated spots within our outpatient clinics to really be able to take referrals. And again, this is just here at the Children's Center, and obviously we think a lot about the overall institutions, right? Howard County, Sibley, Suburban, Bayview, and thinking about kind of how would we build, how is there a sustainable model to be able to build out across. So finally, just to wrap up here, we would love to be able to have better understanding of our patient population. So we have an inpatient comparison group study underway. We need a longer evaluation period to understand our impact. And one of the things I've been really wondering about is what are our best quality indicators: lower ED volume, cost, hospitalization, or sustained kind of clinical improvements. And so really just the beginning, scratching the surface, and I welcome feedback, thoughts, wisdom. Yes, so thank you.
Thank you, Liz. That was terrific. Well, what you said at the beginning about the magnitude of the problem was pretty startling. Those are remarkable numbers in terms of the rise in the need. I'm so glad that you're taking steps to address it, and it was a great presentation. And I could see why it would feel very gratifying to you to be doing this. When you engage, it sounds like I gather you've had some direct engagement with some of these families. And
yeah, so I did the pilot myself for those first 7 months, and then I mostly bridged the inpatients.
okay.
And so
Okay.
yes, I have a lot of my own personal kind of direct clinical experience.
Yeah, I guess the question I want to ask is are there particular things that families tend to really need to hear? The things families tend to not understand about how best to support a suicidal teenager?
Yeah, that's a really great question. I think potentially one of the nice things about Bridge is that you're out of that kind of intensity of the, for example, the emergency department, right? You're in a kind of a space that potentially feels a little less threatening, a little more therapeutic. And so sometimes I almost feel like it's like we're getting an opportunity to have parents who are obviously continuing to be stressed, but an environment that feels slightly less stressful. How about that, right? And so I think providing hope and providing a lot of education in terms of helping them navigate, which can feel like a pretty overwhelming, getting treatment right now can feel so overwhelming for families. I'm sure many of us on the Zoom today can speak to how many people reach out saying, hey, how do I get care? I mean, how do I access services, right? And so helping them navigate that and feeling like there's a good plan and approach and that you're going to help them get to that next level of care, I think can be really, really comforting.
Mm-hmm.
I also think providing education on different strategies to help parents feel more effective in managing the crisis. So working on validation, means for children and parents to be able to be communicating with each other are really some of those kind of key other components.
Great, thank you. Dr. DiPaolo asks, what do you think is driving this rapid increased rate of anxiety and depression? What was driving it before the COVID pandemic, and are the same trends evident in other parts of the world?
Yeah, it's a great question. So I think about this frequently myself, right? What are the trends? And in terms of what we know too from data, I think it's probably not one thing, but right, many contributing factors. I will say in 2011 is when you start to see the data points really peaking up, right? In terms of the increased demand for care, the rates of reported depression and anxiety increasing. And I think that's partially when more people had smartphones, increased access to kind of digital media. And I don't think that's just, it's like, oh, social media is bad, but thinking about other impacts that might have in terms of disruption to sleep, engagement in social networks, both that kind of social evaluation or cyberbullying piece, right, might be part of it, but I think there are other disruptions that potentially at play. There's been some work looking at earlier onset of puberty and the kind of a mismatch with increased kind of intense emotions with the self-regulatory kind of processes not fully developed, right? So I think there's a lot more to learn. And then obviously during the pandemic, what we saw was really just this overall increased stress, right? Stress of managing family health concerns, financial concerns, and then the other piece that I think has come out a lot about is how school connection can be such a protective factor. And so having kids at home during the pandemic away from that school connected, the school connection, I think is, not a really important part of, was one of the big contributing factors. And I think where we can be trying to find some hope in terms of where we can go forward.
Great, thanks. Stuart Barron says, thanks for this wonderful work. Is the Bridge Clinic available to receive a referral from non-Hopkins EDs?
Yeah, no, that's great. We have not done that yet. I think we were trying to get our footing right to understand how to do that, but that's sort of our next step or horizon that we would like to be able to take. I think part of that is wanting to make sure that we were managing understood some of the processes that were at play, but I think, yeah, that would certainly be a next step.
I guess he relatedly asks, is it available in the private world, like medical urgent care clinics?
Yeah, so we have not so far that would not taken kind of what we would call planned crisis, but that has been our next goal to be able to do.
Russ
And
Margot.
oh, sorry. I would also just say as a means to prevent an ED visit, right, to be able to access things like day hospital intensive outpatient programming. So sorry.
No problem. Russ Margolis says, a great program. Can you comment on an effort the state was looking at a few years ago to adopt an established program of in-home crisis interventions for children and adolescents with developmental disabilities and problematic behaviors?
Yeah, so I am aware just a little bit. I haven't been intimately involved in that work. So if anyone else has, feel free to jump on and say something too. But I don't think that in-home crisis has been kind of as fully realized as we would like it to for children. I understand there's quite a bit more work that's kind of underway that, but so far, and this is something that varies quite a bit by county too. In terms of your access to those more crisis care. In Baltimore City, there was something called B-Cars for a long time, and that over time they kind of lost funding. And so it was kind of a less robust program as I think it had once been. Yeah.
Great. Sarah Polk says, thanks so much for this presentation and this work. I'm an outpatient pediatrician at Bayview. We desperately need more of this care that bypasses medical EDs in most cases, given how little can be done in that setting. I don't know if that's a question or just a comment.
Thanks, Sarah. Yeah, I think that I would, if our next step, right, in terms of opening up access, I think our next step would be taking referrals from the pediatric practices across Hopkins. To me, that seems like kind of the next best step, or kind of the next frontier or next step, and then seeing how we can manage that capacity. And I couldn't agree more, as using that as a way to divert from an emergency department visit.
And then, okay, we have time for one more question. Amina Ahmed said, had asked about difference across by race and who gets into the program. And then she continued, were there any differences between, I guess she's, Robbie Berg had responded, and she said, are there differences between who was referred for services versus who utilized them across demographics, race, socioeconomic status, et cetera? I don't know if you know the answer, whether Robbie.
I don't know the answer, except that I would say our overall utilization has been so high that I can't, I don't think there would be differences there. I think the overall utilization has been quite high. Yeah.
And we're out of time, but Carissa Parrish is tuning in from far away to congratulate you on the great talk. Hey, there's Carissa. Hello.
Hey, Carissa.
That was really wonderful. I mean, what a magnificent program. It's fantastic to see. And it sounds like you have all sorts of thoughts about how to make it even bigger and even better going forward, which is great to hear.
Yeah.
Love to be able to help make that happen.
Wonderful. Well, thanks. I'm so glad I was able to share this work, and I'm really looking forward to our next steps. So.
All right. Thanks, everybody. Have a good week. Take care. All.